Good afternoon, everyone. I'd like to begin by acknowledging the First Nations people as the traditional custodians of the lands on which we are meeting today. I'd also like to pay my respects to elders past, present, and emerging, and extend that respect to all First Nations people present today. Thank you all for taking the time to attend this conference session on allied health practitioners' perception of practice sustainability. My name is Christian Hughes, and I work for Health Workforce Queensland, the rural workforce agency for Queensland. And I'd like to acknowledge my co-author, David Wellman, for his contributions to today's presentation. I'd like to start by discussing the current issues regarding allied health practice sustainability that we are aware of. Currently, there are many reports of the difficulties private allied health practices are having remaining sustainable and viable in the bush, particularly in the remote, rural, and regional modified Monash 2 to 7 areas. Several factors are mentioned in the context of contributing to the difficulty private allied health practitioners face in sustainable private practice. Some examples of these are difficulty recruiting and retaining workforce, limited funding and incentives for allied health practitioners to work remotely or rurally, disparate and short-term funding pools, and financial difficulty like Medicare rebates, the cost of infrastructure, and the logistics of running a private practice. Understanding allied health practitioners' perceptions of what factors are limiting their practice's ability to be sustainable is a crucial step in the development of place-based solutions and models to improve this situation. Additionally, to facilitate contextual understanding, two questions will be addressed during this session. Whether allied health practitioner perceptions are different based on their level of rurality, and whether there are significant differences between priority factors for allied health practitioners and another workforce, medical practitioners. Health Workforce Queensland undertakes an annual statewide health workforce needs assessment, which is informed by a survey distributed to allied health practitioners, medical practitioners, nurses and midwives, and practice managers working in modified Monash 2 to 7 Queensland. Our 2022 HWNA summary report is available on our website or through the QR code on the bottom right and offers further detail on workforce overviews, workforce numbers, perceived workforce and service gaps, and of most relevance to this presentation are issue and focus for 2022, which was sustainability and viability. As for the method and participants for this presentation, our online Health Workforce Needs Assessment survey was distributed by email to eligible practitioners. Additionally, a link was available on our website, which was advertised through social media and some of the peak workforce bodies. The Health Workforce Needs Assessment survey contained 3 questions regarding perceived factors influencing practice sustainability or viability. The survey was opened in October of 2021, and responses were collected until February this year. There was a total of 870 responses this year, and the second largest group of which being allied health practitioners at 227. The HWNA survey received responses from allied health practitioners across more than 16 unique health disciplines. The 3 largest groups were psychology, followed by occupational therapy, and then physiotherapy. The remaining top 5 are depicted in Figure 3. The remaining 11 health disciplines are depicted beneath the bar chart in order of size and had fewer than 20 participants each. As for rurality, the largest group of allied health practitioner participants were located in MM4, followed by MM2 and MM6. 3 questions were used to investigate practitioner perceptions of sustainability and viability. One numeric-based question, asking participants to rate sustainability factors from a list of 15 regarding their importance to practice sustainability on a scale of 0, not at all important, to 100, extremely important. Here is the list of the 15 factors identified to be related to sustainability that were provided to survey participants to rate. These factors were decided based on the findings from contemporary literature in combination with anecdotal responses provided to us by practitioners working in remote and rural Queensland. Some examples of these factors include strategies to encourage remote and rural careers, strategies to improve the retention of staff, Medicare funding reform, and better access to place-based education and training. This rating question was followed by 2 open-ended questions asking, what would improve the sustainability and viability of your service, and what needs to change to ensure primary care services in your community are sustainable into the future? Figure 5 depicts mean importance ratings across all 15 sustainability items for allied health practitioners in order from perceived least important to most important. Firstly, it is important to note that the scale of the graph goes from 70 points to 100 points, as no factor was rated beneath 75, indicating that there was a general agreement by allied health practitioners that all of these factors are important to their practice's sustainability and viability, and that the difference between factors is indicative of the order of priority or importance. As we can see, the top 5 factors allied health practitioners overall felt were most important to their practice's sustainability were encouraging rural and remote careers at 90 points, improving the retention of staff, Medicare funding reform, continuing professional development, and support for supervision. In the top 5, we can see 3 factors related to workforce concerns, 1 regarding funding, and another 2 relating to practitioner support. The lowest important rating mean was for technology and telehealth, indicating that it was not as significant of a priority as the factors that preceded it. As mentioned previously, this is not to say it is not important at all, as it was still rated at 75 points on a 0 to 100 scale. When we briefly compare these findings to the medical practitioner cohort who participated in the survey, we see that medical practitioners reported lower importance ratings means by 3 to 11 points on the 13 of 16 factors when compared to allied health practitioners. The largest differences were seen for access to continuing professional development, support for supervision, and infrastructure funding for accommodation, where allied health practitioners were between 9 and 11 points higher than their medical practitioner counterparts. Conversely, medical practitioners and allied health practitioners reported very similar importance ratings means for Medicare funding reform, where it was first for general practitioners and third for allied health practitioners, support for family, and telehealth and technology. When we look at allied health practitioner importance rating means, split into the groupings, with MM2 to 3 being considered regional, MM4 to 5 as rural, and MM6 to 7 as remote, explicit differences start to be visually identifiable. MM2 to 3 had 52 survey participants, MM4 to 5 had 129 survey participants, MM6 to 7 had 39 survey participants, with 7 participants choosing not to report this information. Remote and very remote practitioner means are depicted in red, as their reported importance means were substantially different than those provided by regional and rural practitioners. The regional and rural groups scored generally similar both in magnitude, the value of the importance rating means, and the order in which the factors were ranked. This is not to say that there were no differences between these two groups. For example, regional survey participants ranked infrastructure funding for services as their second highest factor at 90 points, 9 points higher than it was rated by their less rural counterparts. In regards to remote and very remote practitioners, I'd like to draw your attention to 3 factors: support for family, infrastructure funding for accommodation, and the rural generalist model. Remote area practitioners clearly see these as far more important factors than rural and regional practitioners. A potential explanation for this finding is the increased difficulty of finding affordable and available rental accommodations in remote and very remote areas, and the limited family support that is offered to practitioners working in those areas in terms of infrastructure services such as schools and childcare, and family support like access to other relatives. A positive finding is the placement of rural generalist models ranking 8th overall for remote and very remote practitioners. Indicative that practitioners in these areas understand that rural generalist models are an important potential solution to workforce supply issues and the increased scope of practice that is intrinsic to remote and very remote employment. Lastly, it is worthwhile to note that whilst Medicare funding reform, despite having similar means within all 3 groups between 85 and 90 points, remote practitioners reported this being the 4th least important factor when compared to more pressing issues like accommodation, family support, and a rural generalist model. These 3 bar charts depict, in ascending order, the rankings and mean importance scores for a more visual look at the top 5 perceived important factors for each rurality grouping. For similarities between groups, improved retention of staff and encouraging remote and rural careers were present in top 5 of all groups, placed as either first, second, or third most important factors for every group, indicating that workforce sustainability solutions are of a high priority to allied health practitioners currently. Between the regional and rural groups, improved access to continual professional development for remote and rural practitioners were scored 5th and 4th most important respectively. The remote group demonstrated significant differences, with the inclusion of support for supervision, support for family, and funding for accommodation in the top most 5 important factors, suggesting that currently practitioners working in remote and very remote areas believe that fundamental necessities such as accommodation and support for their families are of utmost importance as they are currently not being met in their eyes. For remote practitioners, infrastructure funding for accommodation was the highest important rating mean seen across all 3 groups at 95 points. Anecdotal reports of rental crises in Australia overall, but particularly in remote, rural and regional areas, corroborate this finding as a significant barrier to health workforce and service sustainability. It is concerning to see this being reported by rural practitioners also, ranked as their fifth most important factor. Thematic analysis was conducted on the two open-ended questions provided to survey participants. 250 responses were received across both questions. 4 major themes were identified regarding allied health practitioner perceptions of sustainability and viability. Many comments encompassed more than one theme, and thus the resulting response tally will be higher than the 250 responses received. The 4 major themes were workforce, with the most comments at 104, support, with 103 comments, funding, with 94 comments, and infrastructure, with 33 comments. For the largest major theme of workforce, participant responses were provided under 3 main subthemes. Firstly, the improved recruitment of health staff and the developing of local pipelines, where several comments highlighted that much of the difficulty in recruiting health staff is encouraging people to move from metro areas, and that by focusing on promoting rural allied health work towards the younger generation, for example, new graduates and those with intermediate work experience, may be a potential method to achieve this. Participants also mentioned grow your own models of healthcare, where students in local schools are encouraged to learn about allied health careers in rural communities. Many comments addressed the limited availability of adequate and affordable locum practitioners as a major barrier to recruiting new staff and retaining current staff, due to the limitations it places on their ability to take leave. Many participants also reiterated that better access to locums, or more hopefully a larger permanent workforce, would reduce the work burden on those at the practice during emergencies or busy periods, improving their work-life balance. And then lastly, a long-term focus on increasing staff retention, where some participants mentioned the need for long-term permanent contracts rather than only short-term 12-month ones. Additionally, many participants mentioned the need for long-term retention to increase the size of the workforce to improve work-life balance, as then the workload would better be able to be shared. To achieve this, participants offered many avenues of support that they could be offered to improve staff retention, which leads to our next major theme of support. Within the major theme of support, many comments were requesting improved access and provision of place-based education and training, as well as funding or general support for CPD, particularly training that meets their needs because of their expanded scope of practice. Participants mentioned that better access to online and local training providers would reduce the impact that distance plays as a barrier to professional development. Better management and processes was mentioned by several participants, particularly in reference to poor workplace culture, contributing to poor retention of staff, and that unorganized business processes contributed to increased workload and poor work-life balance. Suggested included management being better informed regarding what an allied health practitioner requires to perform their job. One participant mentioned that communities become distrustful of services with frequently changing staff. The last subtheme was surrounding community integration, where several participants suggested that improving integration into the community, both socially, getting to know who's who, when the events take place, and who their fellow allied health practitioners are, and logistically, in the form of support finding accommodation, accessing services for family, particularly children, and access to professional supervision, would be a welcome addition in creating a more sustainable allied health workforce. Next is the theme of funding and incentives for remote and rural allied health practitioners. Firstly, practitioners frequently commented on the reality that the standard allied health Medicare rebate was not high enough for many private practices to remain viable solely on that method of income. It was suggested by increasing this rebate, it would allow practitioners to bulk bill more frequently and improve their clients' access to these services. Secondly, participants highlighted the need for not only increased funding to meet the increasing demand of allied health practitioners in remote, rural, and regional locations, but also the need for funding models to be reliable and longer term in nature, as short-term disparate funding does not support business continuity planning. Lastly, within the funding and incentives theme, was the need for better incentives, financial and social in nature, to attract new staff and to retain those currently working in remote and rural locations. Suggestions for incentives included more competitive salaries, better relocation assistance, better integration into the community, and overall better work-life balance. Lastly, the smallest major theme identified within participant responses was infrastructure. Participant responses within this theme identified the lack of appropriate and modern physical infrastructure as a barrier to sustainable allied health practice, particularly regarding services like schools, their own practices, and most importantly, the housing market. It is worthwhile to note that a couple of participants specifically mentioned requiring assistance to find rentals, not just the ability to afford them. Several participant responses also addressed the need for better digital infrastructure regarding the internet connections available to remote, rural, and regional practitioners, and subsequently the development of telehealth capabilities to accommodate for the increasing demand of allied health services and the limited workforce available locally. It is important to understand differences in the perceptions of allied health private practice sustainability, as it has the potential to inform place-based models and solutions working on factors that allied health practitioners themselves say are important to them and their communities. Place-based solutions that target factors that have been previously identified by a large sample of practitioners in their respective regions has the potential to have more positive impact on allied health private practice sustainability than simply a blanket solution. Whilst this presentation focused on the perceptions of remote, rural, and regional Queensland allied health practitioners, there is potential for similar investigations to be conducted nationwide to determine if perceptions differ by state and potentially even by profession. I'd like to thank everyone for attending my presentation on remote, rural, and regional allied health practitioners' perceptions of factors impacting the sustainability and viability of their practices. If I may, I'd like to leave you with a single, highly detailed quote received from one of our many valued survey participants who described in detail the financial difficulties affecting their practice's sustainability and viability, but also sharing their passion for what they do and how they help their community. Thank you again, and I'll be happy to answer any questions you may have in the following Q&A segment.